Thank you. All right, so today I'll be talking about when can you treat GSM? And this was kind of an interesting question, but I'll start with what is GSM? So GSM is the genitourinary syndrome of menopause. It's previously well known as vulvovaginal atrophy, atrophic vaginitis, or urogenital atrophy. But these symptoms may be present for many years before menopause, or may not appear for several years after menopause, or in any woman who, of any age, who experiences a hypoestrogenic state. So not just during menopause, but even during other states like lactation, or even hypoandrogen states, such as, like Dr. E mentioned earlier, on oral contraceptives. So GSM symptoms are chronic and progressive. They increase with severity with advancing menopausal age, and they don't improve without any treatment, unlike other vasomotor symptoms which may improve on their own. And so the symptoms include things like vulvovaginal dryness, discomfort, and irritation. There's a lot of urinary symptoms such as dysuria, urinary frequency and urgency, recurrent UTIs. These are primarily the things that, as urologists, you'll be seeing in your office from patients with GSM, because you are not seeing the patients for menopause itself, but you'll see them for these urinary symptoms. And then, of course, there's also the sexual symptoms, such as pain with sex, diminished lubrication, and impaired sexual function in the desire, arousal, and orgasm functions. So just showing some of the changes that happen in vaginal anatomy associated with GSM. So we can have narrowing of the vagina, we have atrophy of the labia minora and resorption, as well as the labia majora. We can have decrease in vaginal length, loss of the rugae, and this is due to reduced blood flow to the vagina. We also have thinning of the vaginal wall, which is what we see on the left side, the thinning of the epithelium, and loss of the rugae. We can also have fissures on the external genitalia between the labia and other external signs in the vestibule and labia. So this might be what you see walking into your office if you were to examine someone with GSM. For many patients with recurrent UTIs who come in your office, you might not think of doing a physical exam, but it is very important to do a physical exam so that you can look for things like this. We have urethral prolapse, we have narrowing of the introitus, erythema, pallor. I would not want to be walking around with my vulva looking like this. It's certainly, I can imagine that this would be very irritating. So this is definitely something that we need to treat. So how do we treat GSM? So a lot of patients come in and they've already tried vaginal moisturizers, and this is on the list of things that they can try. But certainly we want to address the actual pathology here, which is the hypoestrogen and hypoandrogen state. So we use vaginal estrogen, comes in the form of a cream for one. This is the plunger that comes with the container. You can use it as kind of like a tampon applicator. In the words of Dr. Rubin, I say, "Till death do you part." You make an example of, when would you stop wearing your seat belt, or when would you stop brushing your teeth? No, this is forever, until death do you part. And the dosage is 1 gram daily, twice a week for the 1 gram daily for the first 2 weeks, and then maintenance of 1 gram twice a week thereafter. But you could make the argument that they could have a higher dosage than that, even up to daily for some patients. Vaginal estrogen inserts or tablets are another form of treatment, as well as the e-string or the vaginal estrogen ring. The vaginal estrogen ring is nice because you just place it for 3 months at a time. They don't have to worry about it. So for patients who can tolerate that and prefer something more convenient, that's a good option. We also have androgens that we need to bring on board, so vaginal DHEA or prasterone. It comes in the form of a commercially available prescription. There's also over-the-counter versions, as well as you can prescribe compounded creams, and as well as estrogen and testosterone creams. There's also some evidence for the use of vaginal testosterone alone. So these were primarily studied in these two studies looking at patients with breast cancer on aromatase inhibitors because they had some reservations about being on vaginal estrogen. So they studied just using vaginal testosterone, and there's good evidence for improvement of GSM symptoms there as well. So back to the original question, when can you treat GSM? And I wasn't really sure how to answer this, so I thought I would go to the opposite side where we might want to talk about when should we not treat GSM. And so some of the things that have been typically known to be or thought to be contraindications are things like genital bleeding, breast cancer, estrogen-dependent cancers, DVT, PE, or other thrombotic states, liver dysfunction, other things like that. In fact, we have a warning on all the vaginal estrogen boxes, a box warning. If you can't read that, it says, warning, endometrial cancer, cardiovascular disorders, probable dementia, and breast cancer. However, we have no evidence that any of this is real or true, so we're working on removing this, but it still persists at this time. But looking to some guidelines about when we shouldn't or should treat GSM, I looked at the 2020 guidelines from the North American Menopause Society. They say low-dose vaginal estrogen has not been studied in women with increased risk of thrombosis, but may be used with caution given the minimal systemic absorption and absence of hepatic first pass effect, and minimal, if any, effect on prothrombotic factors. So of note, there are large observational studies in vaginal estrogen, nor systemic transdermal estrogen has been associated with increased risk of VTEs. So they're quoting this study from the Women's Health Initiative observation study looking at breast cancer, endometrial cancer, and cardiovascular disease, and this is a prospective observational cohort study that recruited from 40 centers across the U.S., age 50 to 79. They had about 45,000 people in this study with a median follow-up of 7 years, and they looked at coronary heart disease, breast cancer, stroke, PE, hip fractures, colorectal, endometrial cancer, and death. And they found that in a patient with intact uterus, their risks between users and non-users of vaginal estrogen was actually not statistically significantly different in the risks of stroke, breast cancer, colorectal cancer, endometrial cancer, or PE and DVT. In fact, patients who used vaginal estrogen had a decreased risk of coronary heart disease, fracture, all-cause mortality, and global index events. Finally, in hysterectomized women, the risk of each of these global index events were not statistically different. So looking next at estrogen-dependent neoplasias, the guidelines say almost most women with GSM are candidates for low-dose estrogen, although use is contraindicated with women with undiagnosed vaginal uterine bleeding and should be used with caution in estrogen-dependent neoplasia. Furthermore, it says, for a woman with breast cancer, low-dose vaginal estrogen is contraindicated according to the FDA class label. However, off-label use of several products may be acceptable because of their very low systemic absorption. So this was a meta-analysis that they're citing that looked at the safety of the local hormone treatment for GSM in women with estrogen receptor-positive cancer on aromatase inhibitors. And so their primary objective here was to look at breast cancer outcomes for patients treated with local estrogen or androgen therapy and estrogen receptor-positive breast cancers treated with aromatase inhibitors. And their secondary objective was to evaluate the level of systemic absorption, looking at levels in the serum of estrogen, androgens, SHBG, FSH, and LH. So they looked at a total of 11 studies. And they actually found that, so none of the studies actually reported their breast cancer mortality and relapse rate, so they couldn't comment on that. But they found that overall estradiol actually declined, the FSH doubled, and estriol, however, increased, although estriol is a less potent estrogen and has a shorter half-life. So they concluded that the absence of the systemic absorption of the estrogens after intravaginal administration in postmenopausal women with breast cancer was an indirect clue for the low risk of recurrent breast cancer. But this was a more recent publication in the JAMA Oncology looking at vaginal estrogen use and survival in female with breast cancer, just published last year. And they were actually able to comment on their primary outcome of time to breast cancer specific mortality. This was a cohort study, about 49,000 females with breast cancer, and about 5,000 with breast cancer specific deaths. About 5% of these patients used vaginal estrogen therapy after their breast cancer diagnosis. The median follow-up was about 5 years in one cohort and 8 years in the other. So they found there is no evidence of higher breast cancer specific mortality in those who used vaginal estrogen versus those who didn't. There was a small decrease in mortality, actually, found with vaginal estrogen therapy, and there are no increases even after restricting the model to just the woman with estrogen receptor positive breast cancer or woman with using aromatase inhibitors. So back to answering the question, when can you treat GSM? I was told in residency, just for another example, that the only time you don't do a digital rectal exam is when you don't have a digit or you don't have a rectum. And so when can you treat GSM is you should treat that anytime someone has symptoms who has a vulva or vagina.